Oh, it's very serious now. Hello. All right. Good evening, audience. My name is Chris Reisig. You may remember me from such other poorly attended lectures as infectious disease and every other lecture we're given. I'm looking forward to now doing a blitzkrieg on ITE and thoracic and pulmonary pathology. I will share my screen now. Give me 1 second. Oz and Manish, by the way, feel free to do whatever you want in the background. Let's do this. As my slide deck will indicate, I am actually borrowing slides from Dr. Sarah Zaidi. I'm pinch hitting for her, who was previously pinch hitting for Clark Oyang. So I have tried to gussy this up a little bit, but this is a collaborative project, so take that for what it's worth. All right. I'm going to answer my own questions here in a kind of interesting dialectic, but we'll go this way. So we're going to start off with some trauma. If you have a 46-year-old man who has a number of comorbidities and who's in an MVA with a rollover, and he comes in and his chest is doing this. Ooh. The question is, what do you want to do about it? What's the next best step in management? Which means, from purposes of ITE and boards, like what's the next thing you're doing, not necessarily the definitive thing you're doing. And the answer they want, given all of the sort of constellation of findings above, is they want you to intubate this gentleman. So the first thing we'll start talking a little bit about is flail chest. Flail chest is traumatic fractures of the chest wall. You need to have 3 contiguous ribs broken in 2 places in order to get a flail segment. And what's notable and what's captured in the video and what you might have on a media prompt is the paradoxical movement of the chest wall opposite direction of respiration. The interesting thing about flail segment, and just worth knowing, is it's not actually the movement that causes the hypoxemia or is really the reason for intubation in and of itself. It has to do with the fact that there's probably an underlying pulmonary contusion, which is going to worsen hypoxemia, and the flail segment just increases work of breathing in general, is also extremely painful. So often the prompt in these situations is to intubate the patient for adequate pain control, for work of breathing, and for the fact that it's probably going to be very hard to ventilate this patient and oxygenate this patient in the upcoming hours as you begin to resuscitate them. You should CT these patients. These are high energy injuries. There can be a lot of other things that are going on wrong as well with them. And obviously there's concerns for pneumonia on the other side of them in the setting of the pulmonary contusion. Let's talk a little bit about pulmonary contusion in general. This is blunt force trauma, though interestingly, it also can be shockwave trauma from blast. It can be what's called a primary blast injury from a shearing force of a shockwave. Classically, it doesn't show up on the initial x-ray you get in the trauma slot. It's something that develops over the next few hours. It needs to usually be there by hour 6, but it can evolve over the next 24 hours. It's usually both, direct parenchymal injury, but also the subsequent cytokine inflammation of that area that causes capillary leak and poor or just increased or decreased oxygen perfusion. So this is what it would look like, but this is obviously a delayed x-ray too. Shouldn't expect to see this. But if you have a patient who's hard to ventilate after a blunt force trauma to the chest, one thing to think about is an underlying pulmonary contusion for them. In this scenario, we have a 35-year-old individual. I actually can't tell. 1 second. Oh, sorry. Who is coming in with?
Oh, hey, Chris.
Yo.
Yeah. Sorry to jump in. I just wanted to say that flail chest is one of those rare things, right? That we may or may not see, and I often see on the test questions that sucking chest wound is the other diagnosis we don't see that often, and so there might be the management for either one of them as a gotcha kind of answer choice. So just to make sure. I mean, I think it makes a lot of sense, but I see junior trainees kind of miss that. So just kind of keep those 2 things in mind.
Yeah, I'll mention the sucking chest wound in about 1 slide, but yes, thank you. So this is a gentleman here with shortness of breath, coughing, pleuritic chest pain. You are asked which is the most appropriate management steps, and you can kind of get a sense what the chest X-ray is going to show you based off of what your options are: needle decompression, thoracostomy, supplemental oxygen. It's a little hard always on a slide here, but then again, so are the IT images sometimes to see. And if you're looking carefully, you can see that along the apical aspect of the left lung field, there's a small pneumothorax, but the lungs are largely up in general. And the question is, what do you do with these things? So The answer is you're going to provide supplemental oxygen because it is a small pneumothorax and an otherwise stable individual with normal vital signs. And the management of pneumothorax varies depending on how it occurred and the size of it in general, what else is going on. So simple and spontaneous pneumothoraces, the stories you often get on tests is that it's usually a young male. It's somebody who has like marfanoid features or a connective tissue disorder underlying. Sometimes it can be a patient with CF. Sometimes it can be a patient who's older with COPD and blebs or emphysematous lesions. Those are sort of common prompts or starts to these scenarios. If a pneumothorax is small and the patient is otherwise well, the answer is put them on high tension oxygen with this idea that it denitrogenates them, and this helps with lung re-expansion to fill up the thoracic cavity. If it's a traumatic pneumothorax, the management is basically put in a pigtail if you need to. Again, in some cases, you probably could think about high outflow oxygen always for these patients, but you're going to need usually a small tube thoracostomy. In the event you're getting a scenario where there's mediastinal shift, there's jugular venous distension, the patient looks like they're in a shock state or hypotensive, you need to think specifically about tension pneumothorax. This is where you're having over distension of the thoracic cavity, cutting off venous return. It's an obstructive shock state. And the answer is always, the next step is always needle decompression. Needle decompression either anteriorly, second space, or laterally in the fourth or fifth intercostal where you're going to put your chest tube. There are a number of radiographic features that are included on the slide that you might see with the tension pneumothorax. They're pretty dramatic when they show you images of them. The other thing which Manish just mentioned is also the sucking chest wound. This is, again, a kind of a rare phenomenon in which you have almost a ball and valve effect where air can be entrained during inspiration but can't escape during expiration, and so you develop tension pneumo. And the answer they want from you is a three-sided compressive dressing to basically create a valve so that you're allowed to exhale and air can escape during exhalation from the dressing, but it can't be entrained when they inspire because it sucks against the wound and blocks it. And a chest tube will be put on later. But the first step in specifically a sucking chest wound, if you hear those terms, is to put a three-sided dressing on it. If you're given ultrasound images to look at, both of these are examples of pneumothoraces. One is no lung sliding. That's the one on the left. If you put this in M mode, you would have the classic stratosphere sign where you basically just have like long stretches of lines. It's worth noting, and this is sort of worth remembering, that sometimes this can be atelectasis, but I don't think on a test it typically will be. That would be pretty mean and cruel. On the right, what you have is actually pneumothorax, but you have the transition between the pneumothorax and healthy lung, which is why it looks like it's sliding, but then you have a lung point, which is on the right side of the field. You can see it sliding in and out there. And that's the transition point between lung that's up and lung that's down. So you could get either of these for examples of pneumothoraces. All right, you have a 14-year-old female with, let's say, cystic fibrosis who is having hemoptysis, has about 100 cc's of blood in the last 30 minutes, looks uncomfortable, is in distress, is satting very poorly. You put them on oxygen therapy. And again, the question is, what do you want to do with this patient? What's your next step? Your choices are things like positive pressure, which is probably not a great idea with somebody who's having active hemoptysis, physiotherapy, which seems like a cute idea, intubate them or get a portable chest x-ray. And again, with the idea being that they want definitive management or they want sort of a critical action here. The critical action is to take the airway and to intubate the patient. The bigger point of bringing up this topic is to just talk a little bit about hemoptysis. Hemoptysis quantities, like what constitutes massive hemoptysis, depends somewhat on the size of the patient, but classically it's 200 cc's in 24 hours or greater than 100 cc's in an hour. In real practice, obviously, massive hemoptysis is when you see the hemoptysis and you go, oh, that looks like a lot of hemoptysis. That's massive hemoptysis. The most common cause of hemoptysis in general is just bronchitis. It's just small tears to the tracheal tree, usually in the setting of a viral infection. It's small. It's the stuff we talk about, like being streaked on sputum, or sometimes in bronchiectasis. All cause the issue is actually things like pneumonia, abscesses. When it's related to a cancer, it's usually large volume. It's usually erosion into a vessel. So there's sort of massive pulsatile bleeding. These patients look pretty sick and terrible. There are other etiologies too, things like good pastors or GPA, these autoimmune mediated processes. Make sure you're not being tricked with an ENT or with a GI complaint that's masquerading as hemoptysis, but assume it is. And worldwide TB is one of your most common causes just because of the prevalence of TB worldwide, but another thing to think about. only think about why a patient is coughing up blood. If you have a patient with hemoptysis, remember, and you need to intubate them, you want to put their affected lung, if you know it, down so that they don't bleed into their good lung, and you can allow them to aerate their good lung. And if it's right-sided, you're supposed to main stem them. Preferably, you're supposed to intubate them with a double lumen tube so that you can only oxygenate the affected lung, or rather the unaffected lung, and protect it from blood dripping into it as well. So affected lung, dependent position. Okay, here's a 19-year-old female. She is stabbed in the third intercostal space. She is shocky, but she's got okay oxygen. She's got decreased breath sounds on the right, and it looks like she has a hemothorax, and a chest tube is placed, and 1,600 cc's of blood come out, and they want the next best step in management. Your choices are getting a CT, a thoracotomy, a chest tube, another one, or some oxygen. And what they're, again, in the same vein of intubating the prior patient, they want you to think about like sort of critical actions that will save lives. So what they want you to do here is go for exploratory thoracotomy. And the reason for this is because of the amount of blood that came out when you first placed the tube. So like hemoptysis, hemothorax, the amounts that count as large volume or straight to OR kind of vary by size to some degree. Though classically it's 1,500 when you put the tube in, or greater than 200 cc's per hour for the first 3 hours. Obviously, anyone who's shocky, who's not responding well, who's decompensating, who looks like they need to go to an OR for definitive hemostasis will go to an OR. But those are kind of the numbers. And in the prior question, that's what they want you to think about, is actually just the amount of volume that came out with the tube going in the first place. These are the steps of a thoracotomy. I don't know how often this directly gets tested. I think the important thing to kind of keep in mind for purposes of ITE is the first thing you're doing once you enter the chest is deliver the heart. Sometimes I think you're asked about like how you're going to deliver the heart, and remember that you want to do a cranial caudal or caudal cranial incision anteriorly parallel to the phrenic nerve, not transverse, but parallel to, and do it anteriorly to avoid the phrenic nerve as well. And after you deliver the heart, and assess it, you're going to ultimately try to cross clamp and or compress the aorta to improve perfusion. Those are critical steps. Let's talk a little bit about bugs in pulmonology.
Oh, hey Chris, I don't know with the thoracotomy if they'll mention anything about the clamshell is better
Yeah.
than trying to do the just the left side stuff, but that should be a better approach.
Yes, I agree. I think there's lots of data that would suggest, especially if you're coming from a facility that does not do thoracotomies all the time, the clamshell is far superior in terms of access and being able to actually accomplish this procedure. Moving on to the issue of bugs. All right, you have a 33-year-old male with a cough, pleuritic chest pain, weight loss, night sweats. His vitals are kind of okay. He's got crackles and decreased breath sounds on auscultation. You get the following chest x-ray. We haven't shown it to you yet, but they're asking you which do you think is the most likely: lung abscess, neoplasm, septic emboli, or TB. So none of these things are good, and the answer is not simple pneumonia. And here's your chest x-ray. And the thing to notice about this, and if you happen to have been at the prior infectious disease ITE, you would have noticed I used the exact same x-ray, because this is probably the x-ray that's always used when they're talking about lung abscesses. It's a fairly circumscribed, isolated lesion. It has a very clear fluid level, which I don't know if you can see my mouse, but it's right about there. And that's really your key sign that this is a lung abscess. Nope, sorry, lung abscess. There we go. Usually they present with a kind of more protracted course. It can often be sort of look like B symptoms. So you have to think about the other etiologies that could be causing protracted pulmonary symptoms with B symptoms. The consolidation with the fluid level is the thing that you really want to think about. Sometimes this is often gram-positive organisms. A good story you might have is somebody who had influenza and then developed a MRSA lung abscess on the other side of it, because things like flu impair ciliary motion. And that's a pretty good setup story as well. Sometimes it's people who have a drinking history, alcoholics, diabetics, but those are the patients you should be thinking about who are going to have lung abscess as a ultimate diagnosis. Just to talk about some of the other things on that same list, septic emboli, because we're talking about pulmonary here, the type of septic emboli we care about are usually going to be the prompt is going to be about an IV drug user, because Typically, pulmonary emboli or septic emboli to the lungs are coming from the tricuspid valve, and these are more common in IV drug users and are usually staph related. And you have these multiple small lesions, and they're subpleural. So if you look at a chest X-ray AP, they kind of look like this. They almost look cannonball-y. But if you look at a CAT scan, you're going to see that they actually adhere towards the periphery of the lungs. They can also be accompanied with parapneumonic effusions and empyema. But it's the location of these and the that are going to clue you in that this is a septic emboli, and they need broad spectrum antibiotics that cover gram-positive organisms, including MRSA, to consider. To talk a little bit about empyema develop in the pleural space. They all can often have a surrounding parapneumonic effusion. Patients typically look sick. If you're asked about the criteria to know if something is in fact an empyema, it should look purulent when you drain it, and it should have one of the following criteria. It should have a low pH, it should have a low glucose or high white count, which kind of makes sense. This is an acidic, gross pocket of infection. Elevated LDH, I think over 1,000 is also a criteria. It's not on the slide. Keep in mind that in addition to broad spectrum antibiotics, you also want to get source control. So you're going to need to drain this. It can't sit there. It actually has to be drained with a pigtail or some other type of ultimate source control. So there you have for empyema. I threw this in here just because it's always in here. This is the lights criteria. So this is how you determine whether or not a fusion is exudative versus transudative. This is always tested for reasons that are a little bit beyond me. The most important way, the way I keep it straight in my head, is to think about the fact that a pleural effusion that's transudative is all about pressure. It's about hydrostatic pressure. So it's mostly water in that space. It doesn't have a lot of stuff in it. By contrast, exudative effusions have stuff in them because it's being pulled in by some other force, like a malignancy, for example. So when you're thinking about Light's criteria, and if you can't really remember in the moment, like what is the exact ratio, remember that an exudative effusion is going to have more stuff in it, or it's going to look more like the serum than a transudative is going to. So you're going to have a higher pleural to serum protein ratio in exudative, higher LDH to serum ratio in an exudative. That's kind of how I think about it. There's more stuff in exudation, and so the ratio will look more like serum if you can't remember the exact criteria. And by the way, you need one to make the criteria. Talking a little bit about TB, I'm going to move really fast. It's an acid-fast bacilli. Remember that primary infection is through aerosolized droplets. It's highly infectious. That's why we use N195s. It can have hematogenious spread. If you're able to wall it off, you may get what's called a Gone complex, which we classically see, which are perihilar. But you can also have disseminated TB at your first infection or at your primary infection. It often takes a miliary form. This is what miliary TB looks like. If you happen to get a chest X-ray, it looks like small milia, small grains of rice throughout the lung field. For many people, there's a primary state, and then they go into latent TB, which can be reactivated either in the setting of a malignancy, immunosuppression, which is why you hear about it with all these immunologics on TV these days. HIV patients, classically, it's an AIDS-defining illness. And you're going to have B symptoms, nights, sweats, fevers, chills. Often the prompt will give you an individual who has sort of a risk factor for this. Either they were born in a country where there's high TB prevalence, they were incarcerated for an extended period of time, they are undomiciled living with a homeless community. It's usually not subtle. They're usually trying to give you some story about a vulnerable individual in that regard. There are obviously extrapulmonary manifestations of TB, including meningitis. I think we talked about this last time, but the hallmark of CSF meningitis, TB meningitis, is very high protein, much higher than in any other type of CSF meningitis. But it can go in a lot of different places. And again, beyond our purposes here, but remember, TB is not just pulmonary. Treatment is ripe. It can be de-escalated, but that's usually not tested since it's not an emergency room problem. Remember that patients who go on isoniazid can develop seizures and neuropathy, and if they're seizing and they're giving you a TB history, remember to administer B6 to them, which is the antidote, not a benzo. Though benzo is not a bad idea to do too, but B6 is what's going to fix them. If you're given PPD questions, and I talked about this last time, remember the more immunocompromised you are, the smaller your reaction to the PPD inoculum has to be. So people who are HIV positive, AIDS positive, do not need as big a wheel as somebody who's immunocompetent. Please also remember too, because it's a pediatrics issue, that children under 4 do not need a particularly large wheel as well. And if they are in a household with somebody with TB, they often will get presumptively treated. So people with high risk have lower thresholds for a positive PPD. There can be false PPDs too. Remember, anyone who's been who's internationally who's received the vaccine can have a false PPD. I almost feel like there's some lupus, like APLS, may give you a false too. There are other people who can get false PPDs, but or anyone who's had exposure to MAI or a MAC can have it too. A non-TB mycobacterium can have a positive PPD as well. And it's remember too, it's also the erythema. What matters is the wheel, not the erythema, the induration, not the erythema. That's what you're measuring. 75-year-old man, fever, altered mental status, has a peg tube. You can kind of see where this is going already. They have respiratory symptoms. Their SAT is pretty poor. They have a chest x-ray that shows a right upper lobe consolidation with an air fluid level, and they're asking you how you want to treat this person. So you're kind of getting a picture that this is probably some sort of aspiration-related pneumonia. And the question is, well, what do you need to treat with them? We know CAP coverage is ceftriaxone and azithro. It works for a lot of things, but obviously that's not what we're looking for here. Levofloxacin is usually like a second line option for CAP as well. It's probably not the best choice here, certainly not supportive care. And what they want you to go for is the unison. And really what they're driving at here is that when we think about aspiration pneumonia, we need to think about anaerobes. These are GI flora that have made their way into your respiratory tree. And so you want good anaerobic coverage. Unison provides that. Zosyn provides that. The real difference between Zosyn and Unison is pseudomonal coverage for Zosyn, but either one would be appropriate. In aspiration pneumonia, we often think about patients with an alcohol history, patients with neuromuscular disorders, former strokes, people who can't protect their airway as much, or who have TBIs, things of that nature. Checking with the question. Okay, good. All right. How about 35-year-old man, dyspnea for the past 10 days, 15-pound weight loss over 4 months, satting poorly. He has bilateral interstitial infiltrates on his chest x-ray. He's gotten broad spectrum antibiotics, but they want more from you. They want more than just CAP. So they're giving you these other things. And the trick here is to recognize that he has what seems to be this protracted weight loss. It seems to be sort of subacute to chronic, and now he has bilateral infectious infiltrates, which makes you think that perhaps this gentleman has HIV or now has AIDS because he has PJP pneumonia and needs Bactrim. So PJP pneumonia, also known as PCP pneumonia, previously classically has this bat wing appearance on chest x-ray. We usually see it in patients whose CD4 count is below 200. The things to know about it and that you're going to be tested on is they want you to send an LDH because it's typically elevated during clinical infection. And if a patient has a low oxygen saturation or a low PaO2, or by extension, a widened AA gradient, you're also supposed to give steroids. So in this prior example, since this gentleman was hypoxemic, he's also supposed to get steroids on top of his Bactrim. Sometimes they ask if a patient has a Bactrim allergy, atovaquone is a second line, dapsone is a second line, but Bactrim is the mainstay of PGP therapy, just to know that. All right, we've changed backgrounds. This is the person with cystic fibrosis, 26-year-old male. He's got some sort of pulmonary infection. Which of the following is the most appropriate therapy at this time? The key here is that this is a gentleman with cystic fibrosis. So you have a number of good, fairly broad spectrum antibiotics, but only one of them covers from Pseudomonas, and that is cefepime, and that's what this gentleman needs. Cystic fibrosis, sodium chloride channel mutation leads to very thick secretions. It's important to remember that in early childhood for cystic fibrosis patients, the causative agents we worry about are the ones we worry about with all kids, like including Staph aureus. But as they get older, the predominance of Pseudomonas grows and grows, and that's the thing we worry the most about. In a perfect world, you treat a cystic fibrosis patient based off their last sputum culture, which they get fairly frequently, to make sure you're treating what's actively in their lungs. There's reasonable evidence to suggest that you should be double covering for Pseudomonas in these patients. So they need 2 different agents that will cover for Pseudomonas because there's mortality benefits when you aggressively treat their Pseudomonas, because that is what kills these patients very often. Don't forget the bronchodilators. Don't forget to actually help them get up their secretions. But the main thing to know about is cystic fibrosis symptoms. Okay. By contrast, here's just a healthy 32-year-old guy with a week of fever, dyspnea, similar cough. He's got a negative chest X-ray, but he just keeps coughing and coughing and coughing. What do you want to do for him? And the answer here, because it sounds like he has what everyone in New York has right now, which is a bronchitis, is to treat his cough with some dextromethorphan. So bronchitis is a cough that won't go away for greater than 5 days, that without parenchymal involvement. There's lots of causative agents for this. We are very familiar with them at this time. There are some bacterial etiologies, but overwhelmingly it's viral. The mainstay of therapy is symptomatic support. So that can be mucolytics, it can be cough suppressants, it can be expectorants, depending on what's bothering the patient the most. There's limited evidence to use things like prednisone for patients who have some evidence of reactive airway disease. Albuterol tends not to work them, but we tend to throw a lot of things at patients who have this. But for testing purposes, there is not much evidence supporting Amox, Pred, or albuterol for bronchitis, so they want you to just treat the cough as needed. All right, let's talk a little bit about other things that can go wrong with lungs, and I'm going to speed up a little bit. So what triad tells you you have a fat embolism? Without going through all of them, the word that jumps out to me when I saw this question is petechial rash. That's the thing that's going to tell you have a fat embolism. There are all of these things that we're tested about sometimes that are exceptionally like case report rare sort of things, but somehow we're expected to know about them, including fat emboli. So the ones I want to focus on, the ones I've seen at least on my testing, fat emboli are develop in the setting of usually long bone fractures, classically like a femur fracture in a patient who goes into profound respiratory distress and looks like a PE, but it's too soon to be an actual PE. And the testing feature that they always give you is they develop this petechial rash at the time, which, to be honest, is actually a very late stage finding in fat embolism. But for purposes of testing, it shows up at the same time as their respiratory distress. The management is symptomatic. You can't lyse these people. There's no TPA or tenecteplase. I guess now we may increasingly see VV ECMO as an alternative for them to basically take their pulmonary circuit out of commission. But fat embolism, we think about petechial rash, long bone fracture. Amniotic fluid is going to be not that subtle. It's going to be a woman who just had usually some sort of complicated delivery and then looks like a PE. And again, they want you to think about amniotic embolism, again, treated symptomatically or with ECMO. The other one you sometimes see, I think, more is gas emboli. This can be like an air embolus in the setting of somebody who just had a procedure done, like a central line or a cordis or something like that. It can also be like the chokes, like a person who's having decompression sickness as a diver and comes up suddenly and has rapid extravasation of nitrogen, or rather conversion of soluble nitrogen into gas in the blood, and that can cause an air embolus, among many other things too. Again, management is symptomatic, high flow oxygen, and potentially VV ECMO to take out the lungs. All right, you have a 19-year-old lady with a history of asthma. She is getting bad. She needs to be intubated. What are you going to use for it? The answer here, based off the ones we're given for this asthmatic woman with an asthma exacerbation, so we're going to use ketamine. Sorry, I should have lit up there. The question here is really getting at, do you know the benefits and downsides of all your different induction agents? With etomidate, remember, it can cause some adrenal insufficiency and sepsis. That's usually an upstairs problem. We don't think about it too often. Propofol causes hypotension, which is why we don't use that often for RSI. Ketamine has a number of advantages for RSI. It is bronchodilatory. It allows you to continuously respire. Remember that it does cause laryngospasm, and you can go apneic if it gets pushed quickly, which is how we're often pushing it in RSI. But keep those things in mind. Fentanyl and midazolam really don't have a role in RSI for us anymore. Remember, Sux is depolarizing, Rock isn't. You want to avoid Sux in anybody who is at risk for hyperkalemia, who has a neuromuscular disorder, or has like a crush injury where you're concerned that there may be a lot of extra potassium floating around. So when in doubt, use Rock, though the delay of time of onset is slower. Moving on, you have a gentleman who's in the park. He's got asymmetric wheezes when he's found, and he's got a very low GCS. He's intubated, and it shows that he has a foreign object in his bronchus intermedius. Who knows what he's doing in the park? Which lobes are most affected by the airway obstruction? I'm not really sure you're all going to be asked about lobes directly as much as they want to make sure you understand some rough sense of the tracheal tree. And the reason why foreign bodies tend to go into the right lobe, and that's because the right bronchus is a more direct shot off the carina from the trachea. The bronchus intermedius is an extension of the bronchus, the right bronchus, and it has two segments that go off of it. So most likely the affected lobes, if you were answering this question, are right middle and right lower. But the idea here, and the main thing they want you to know, is that most foreign body aspirations end up on the right side. If you took an X-ray, you want an expiratory X-ray where you'll actually see that the affected lung, the obstructed lung, will look larger because it can't actually expire as much as the unaffected lung, as one way of determining which side the aspiration is. Treatment is supportive care and bronch, get the thing out. And often the setup for these stories will be there'll be a young child who was left unattended for a few minutes and then is coming back with a wheeze or stridor. Sometimes it's an adult with a developmental delay, but it's usually somebody who's briefly left unattended and then suddenly it develops a problem. Okay, you have a 40-year-old male. He's coming from base camp, 6,000 meters, very high up. He is satting poorly. He has diffuse edema on a chest X-ray when he gets to the nearest medical facilities, and it's asking what's the mechanism behind his symptoms. So it's assuming you know that this is probably HAPE or high altitude pulmonary edema, but it wants you to ask why this is happening. And you may not know, but you could probably rule a lot of these things out. It's unlikely that he has an infection in the moment. It's unlikely that his LV is shutting down, and that's why he's developing this. Low PA pressures you might be uncertain of. The answer here is microvascular hypertension. And the reason for this, if you think about it, does make sense. We know that when lungs are in a low oxygen environment, they vasoconstrict to realign their VQ. The problem is if the entire lung is not seeing oxygen, the whole lung increases its pulmonary hypertension, and this can cause basically cap leak and alveolar leak. HAPE is on the spectrum of different types of altitude sicknesses. It is often on tests. You'll hear people having like pink frothy sputum. They'll have dyspnea at rest. The initial treatment, if you're asked for an initial treatment, it's just oxygen. Just give them oxygen and it will relieve some of the pulmonary constriction and make things better. The definitive treatment is descent. Hyperbarics can be used too. There's maybe some role for nifedipine or calcium channel blockers or like PDEs, like the phosphodiesterase inhibitors. Those are all kind of down the line. At the end of the day, oxygen is your first line, and then definitive is descent, safe descent when possible. It leads us to a sort of larger conversation about non-cardiogenic pulmonary edema in general, things that can cause pulmonary edema that are not directly related to the heart. It's important to remember what makes something non-cardiogenic. You need bilateral infiltrates, meaning it's not just like a lobar pneumonia. You need a normal pulmonary cap wedge pressure, which means, again, it's not the heart. The PCWP is a proxy for left atrial pressures and basically a proxy for left ventricular function. So you have to have it. We have, by definition, this can't be a left ventricular failure that's causing this. There's lots of things that can give you non-cardiogenic pulmonary edema. ARDS is the one we think the most about. I'll talk about a little bit about that. HAPE. You can think about neurogenic causes. You can think about, we talked a little bit about pulmonary effusions in trauma earlier. Narcan-induced pulmonary edema, which I actually saw yesterday. Toxicology can also do it too. Think about salicylates. This is actually indication for HD. And inhalational injuries too. Hydrocarbons can do this, is one that comes to mind quickly. So think about other reasons that a patient could have non-cardiogenic pulmonary edema. This is what it looks like. It looks like broad whiteout bilaterally. It looks bad. And if you're treating this, the main thing we want to do is avoid further lung injury. So you have all of this fluid that's leaking into you, having difficulty oxygenating. Patients typically need mechanical ventilation, but they need to be ventilated safely. The way this usually comes up on tests is to talk about patients who have ARDS or ARDS. ARDS is defined by having a P to F ratio less than 200 or less than 300 if you're on PEEPs already, depending. The main thing is use a lung protective strategy. That's usually what's tested. So 6 cc's per kg is a good number if you're going to remember any number, and avoiding plateau pressures under 30, or sorry, avoiding plateau pressures above 30, staying under 30 is what you want to do. If you have to allow for permissive hypercapnia, that's fine. It's more important that you don't cause further lung damage rather than worry exactly about their ventilation status. And you can prone and you can maintain their O2 sat at lower levels. This is what we did in COVID, but it's the mainstay of ARDS care in general. By contrast, pulmonary hypertension is a cool topic. It comes up in different ways on this test. Here, the problem is basically with increased pressures throughout the pulmonary circuit. It's not necessarily a problem of the alveoli, it's a problem of the vasculature leaving to the alveoli typically. There's a number of different reasons for it. There are different types of pulmonary hypertension. I don't think I've ever seen you asked to pick the class it's in, but it's important to know that there's a wide variety of them. Group 1 is pulmonary arterial hypertension. This is the smallest group, but it's also the group that gets all the cool meds like Remodulin, the prostacyclines, the ETANs, the endothelin receptor antagonists, the PDE5 inhibitors. These are people who actually have hypertrophy of their pulmonary arterial system, and so they have thin lumens, and they basically have high resistance throughout their pulmonary arterial circuit. These are really sick people. The biggest group is left ventricular failure, is group 2, people who have right heart failure as a result of left heart failure. Group 3 is cor pulmonale. Group 4 is related to pulmonary embolism. People have chronic pulmonary embolism. This group can phenotypically look like group 1. They actually end up having similar pathophysiology. And group 5 is we don't know everything else. Sarcoid is the one that often comes up in this group, but again, just we don't know why these people get pulmonary hypertension. I don't know if it was Clark or Sauer who found this awesome slide, but this is if you wanted to remember, there's this sort of neat way in which if you mirror it, it can kind of help you remember which group is which. Again, I don't think it's that important that you know which group is which, other than to recognize that pulmonary hypertension has a lot of different looks about it. And the mainstay of therapy for almost all of these patients is maintaining good oxygenation. They need aggressive oxygenation to diminish the degree of pulmonary hypertension they're experiencing or PVR they're experiencing. They often need volume management too, which can be diuresis with pressure support because they tend to be overloaded as well. So aggressive oxygenation is what you need to know about them. And usually they're diuresed as well because they tend to be volume up, secondary to chronic right heart failure. All right. 66-year-old male, dyspnea on exertion, smoker, but no history of lung disease. He's been having symptoms for 6 months now. And he has a chest x-ray as shown. Which of the following is most likely diagnosis? If you look at the answers, you can know it's not going to be something straightforward, right? It's pneumoconiosis, bronchogenic carcinoma, flu, heart failure, pulmonary emboli, and then you get this chest x-ray. I've seen this x-ray before. I think it's actually really hard. It can give you a lot of pause, but I think the main way you would answer a question like this is just reflect on the fact that this patient has been having symptoms for 6 months. So it's unlikely to be a flu. It's unlikely to be heart failure because it looks more one-sided than another. It's unlikely to be a PE, which leaves you with carcinoma or with a pneumoconiosis. And the answer here is because of the way these things sort of adhere to the periphery of the lung more, that this is actually a pneumoconiosis. That's how you're supposed to differentiate this from a more mass lesion like a carcinoma. It's a little hard, but just sort of the way I think the thought process works. And this is asbestos-induced pneumoconiosis. We think about asbestos primarily usually as a causative agent of mesothelioma. Remember, the mesothelioma is also like a pleural-based cancer. So when you also get the hypersensitivity pneumonitis of asbestos, it's also going to be primarily pleural-based as well, with thick plaques. This is tested. It's and really annoying is kind of knowing where it's more likely these hypersensitivity pneumonities occur. So things like asbestos and cobalt mining tend to be lower lobe processes, and silica. So silica's up. Silica, beryllium, and coal miners' lung tend to be upper lobe. So I didn't highlight these things, but they are. So if it's a coal miner and it's upper lobe, it's probably coal miner's lung. So anyone who's working in the aerospace industry has berylliosis until proven otherwise. Anyone who's in mining or quarrying probably has a silicosis. These are all hypersensitive pneumonitis. Remember that there's not just these types. There's also the things like bird fancier's lung, which are caused by like bird proteins. There's cheese maker's lung. There's cork maker's lung. These are all hypersensitivity pneumonitis. They are treated with steroids or immunomodulators. That's the mainstay of them. They're interstitial lung diseases caused by hypersensitivities, and so they're treated with immunosuppressants and aggressive lung care in general. But think, coal is in the ground, but it's it goes up high. Asbestos is usually in the pipes up high or in the roof, but it affects down low. They kind of inverse. That's like one way people try to remember these things. These are some of the other ones that you'll sometimes see. Yeah, there you go. It's not really worth spending too much time thinking about these things other than knowing they are tested, and there are buzzwords associated with them. Fluorescent light bulb factory is borreliosis. Yeah. All right, 65-year-old man, fatigue, 20-pound weight loss for the past 4 months, 2 weeks, progressively weaker in both his arms and legs. Last bowel movement was 6 days ago, despite trying fiber supplements, sluggish reflexes, brief muscle activation, and he has this thing. So obviously he has a mass lesion right there. The question is what type of mass lesion? And the answer here is a squamous cell carcinoma. And this is also a kind of hard one. We don't think about this too much. But the reason for this is basically, we can kind of logic through it. So again, mesothelioma are plural based. They're not central, they're peripheral. It's large, which and the picture of having like poor bowel movements and being weaker is suggestive maybe of a hypercalcemia of malignancy. So classically, squamous cell carcinoma are associated with a hypercalcemic state with a paraneoplastic hypercalcemia. By contrast, adenocarcinomas tend to be more peripherally located. They don't usually have these neoplastic processes associated with them. Small cell lung cancers can also have like neuroendocrine symptoms as well. But the hypercalcemia is classically squamous cell carcinoma. So that's what they kind of want you to clue in on here. And the treatment is, and the ED treatment to start is aggressive hydration. 62-year-old man, history of hypertension, hyperlipidemia, daily tobacco use, presents with atraumatic right shoulder pain. On exam, he has ptosis and meiosis. This is something we probably are all pretty kind of clued for from steps and shelves. This is some sort of Pancoast tumor, but the question here is, well, what's being compressed? And your options are brachial plexus, a recurrent laryngeal nerve, a stellate ganglion, or the superior vena cava. This is annoying, but you can kind of reason through it. Superior vena cava is usually like the plethoric state when it's being occluded. It's the person who's just ruddy and the whole top of them looks all red and the rest of them doesn't. Recurrent laryngeal nerve is a hoarseness, goes around the larynx. It's about hoarseness. Brachial plexus is what we think about with the arm, which leaves you with the stellate ganglion. And here's your Pancoast tumor up high. Remember that this takes out sympathetics, of which the stellate ganglion is one of them. That's why we have a stellate ganglion block in VT Storm, right? We're trying to take out sympathetics in that. So the stellate ganglion is part of the sympathetic chain. When it's taken out, you have unopposed parasympathetic tone, and that's why you get the meiosis and the ptosis. You lose the tarsal activation from the sympathetics to the eye, which is why you get the ptosis. They just want you to know it's there. That's really kind of it. And that is what I have. It is 9:25. I'm happy to take questions from the field. Any questions on any of that, or not even questions, anything from our expert educators that they would like to add on any of those topics that I glossed way too quickly. No.
Very nice job, Chris.
Thanks, Alice. All right. Thank you all. Good night. Good luck, Raleigh.
Raleigh, you there? Well, she's got to be there. She's still got 5 minutes. All right, we'll take 5 minutes and be back at let's see, what time is it now? 9:30 to start dermatology emergencies. Okay. Hey, Raleigh.
Hi, Oz.
We,
Here.
yeah, no, Ariana's here though.
Oh, still? Okay. I couldn't tell if anyone was here but us two at this moment.
Nope. We, so I'm not sure what the reason is for the low turnout, but Chris basically ran it like a lecture so that we could tape it. So I will just ask for you to do it the same way, I guess.
Okay.
It makes it go quicker. It just makes it less interactive and more of a lecture format, but whatever, it's fine.
It's a little bit of a boring subject matter anyway.
Teach me
So,
something, teach me something.
Oz, do you listen to all of these? No
Yeah,
way. Oh my God.
not just once either, every
Right. I
year.
mean, oh, look, see, mine still says 2023 because I have not did almost nothing to it. But okay.
Well, I don't think that most of the emergencies change all that much from one year to the next, so I think it should be fine.
Okay. All right. Do you want me to go? You can see my thing?
Yeah, let's see, it's 9:30 now. Yeah, I guess it's safe to start.
Okay, but you can see my little dermatologic emergency screen?
Oh yeah, you're up. You're up.
Okay, well, hello. Lovely to see everybody. We are going to talk about dermatologic emergencies, sort of from the angle of test question, a test question angle, but it is good to refresh these things, even though it's a little bit of a dry topic to like teach. It can be a little boring, but we do see a lot of rashes in the ED, and it definitely can be useful in our day-to-day lives. But yes, mostly also for board prep. So here we are. So you see a rash, now what do? All the same normal things you always do with all of your chief complaints. So you want to find out the history. When did it start? How long does it last? What makes it better or worse? Are there any known allergies? That's always a popular question. Have there been any new exposures to soaps, lotions, foods, new medication? Is it painful or pruritic? What's the distribution and evolution? So that's actually really key for a lot of rashes, especially on test questions, as far as like it starts on the face, moves down, starts out and moves in. That's often your key, especially with the pediatric exanthems. It's often your key to sort of diagnosing which rash it is. So the distribution, the evolution, the associated symptoms, like every other HPI you give, all the past medical history. And then in the back of your mind, when you're seeing someone with a rash, you want to keep in your mind, can't miss diagnoses. This is more clinical than test question, but things that we really care about in the emergency department as far as what would be, dangerous. So it's all about basics in the beginning, right? I mean, you don't come up to your attending or whoever your senior resident and say it's a rash. You have to be able to describe it. You want to use the appropriate the words to describe it to us, to each other, and especially if you end up talking to a consultant, you'd like to sound like you know what you're talking about. So just to go over the words, erythema is not just redness. It's erythematous skin. It's red skin that's secondary to vasodilatation. So this should blanch. It's a specific type of redness. Induration is dermal thickening that's palpably thick, palpably firm. And a wheal is the same as urticaria or hives, and it's a well-circumscribed lesion. It's secondary to dermal edema, often pruritic. So it's often what we think of for allergic reactions, but you want to know the actual words to describe these rashes. So here's some more very boring but important things that we see all the time. A macule is a flat, not palpable, well-circumscribed lesion of the skin with color change. A plaque is an elevation above the skin where the width is greater than the height. So like you might see in psoriasis, for example, in that picture. Other basics, a nodule, we see that a lot. Elevated superficial solid lesion, so not fluid filled, greater than 0.5 centimeter, and a papule is the same thing, just smaller. And then we have other types of redness that are not erythema. So there's purpura, So that's an eruption due to extravasated blood. So it does not blanch. It's not due to vasodilatation. So it's another type of redness. And then there's just size differences. So ecchymosis is when it's greater than a centimeter. The lesions are greater than a centimeter, and petechiae are less than 3 millimeters. So really, really tiny. So you want to use these appropriately. Still more vocabulary, basics, vesicle, we do see these, fluid-filled circumscribed lesions less than a half a centimeter, and bulla is the same but larger than half a centimeter. And pustule is pus-filled vesicles. So those are your basic, we use the word blister a lot for these things. It's not accurate. Try to use vesicle or bulla if you can, to be more elegant. So red flags, things that should make you concerned when you're seeing someone with a rash, things to think about are fever for sure, extremes of age, as always, a toxic appearance or abnormal vitals like any other complaint. Consider whether a patient is immune compromised. Again, like I said, consider a recent or new drug. And it doesn't have to be the day before. As we know in some of our drug rashes, like Stevens-Johnson's and erythema multiforme type severe reactions, that can happen weeks later, like several weeks later, because it's delayed type 4 hypersensitivity. So make sure you're not just asking about, new drugs within the last day or two. Other red flags, body, joint pains, arthralgias, severe tenderness, and exfoliative disease. So sloughing of the skin, mucous membrane involvement, those are things that should make you more concerned about rash. The good news is a lot of rashes are benign, but you always have to keep these things in mind. So, however you want to say this, dermatitis or dermatitises, there's a few of these. We see these a lot more in Mint Army than you guys see, but atopic dermatitis is like eczema. Eczema is a common name for it. Often comes in a triad where you have allergic rhinitis, asthma, and eczema. This is a chronic inflammatory and pruritic skin condition, and it's worse in the winter, worse with dry weather. With infants, you'll see it on the face and scalp. Improves for infantile atopic dermatitis, should improve at 2 or before. Treatment is antipruritics, hydrocortisone, topical steroids, usually only oral if it's like very, very, very out of control. Main concern for this is secondary bacterial infections from scratching, open skin. And then there's another possible complication is eczema herpeticum, which is a widespread HSV infection in patients with underlying atopic dermatitis. So something to keep in mind, like a board question. Here's a photo of some classic atopic dermatitis or eczema in a flexural fold. It's a common location. Other dermatitises, contact dermatitis. We see this quite a lot also in the ED. So like I said, so this is a delayed type hypersensitivity. There's pruritus, there's erythema, you can have vesicles, you can have bullae, depending on the size. Things that can cause this, metals, especially nickel, can cause a lot of contact dermatitis. You'll see someone with like, the shape of a ring or a shape of some type of jewelry if it's made of nickel. Also detergents, hair dye. A lot of times in the ED, we see people who have like their lashes done with dye, and then they end up with a dermatitis around their eyes. So all types of allergic contact dermatitis. Another type is poison ivy, poison oak, and sumac. Now, we're not going to see a ton of that in our ED. We see much more like the nickel jewelry contact dermatitis, but it's important to know about, and you need to know it for boards. So there's this antigenic resin called urushiol, and that's the stuff that contacts the skin and causes the dermatitis. So the lesions are often linear, often because of the way you like walk past plants and they sort of scrape or like drag against your leg or your arm. The rash itself is not contagious. That's actually more, I think, personally interesting than necessarily a test question. It could be a test question just because I feel like a big deal is made of not touching the rash and touching something else, but it is not itself contagious. First time you get poison ivy specifically or poison oak, one will have a rash quite a while after the exposure, like over a week, maybe 2. If it's happened before, then it's just gonna be a day or 2 after. The treatment is removal of the allergens. So if you've just been hiking and it's on your clothes, get rid of that. Antihistamines for symptoms, topical steroids, and oral steroids if it is very severe. Here are some images. There you have on the left that ring picture of contact dermatitis, and on the right you have your poison ivy. Other dermatitis, there's seborrheic dermatitis, which we see places where there's hair, sebaceous glands. It's flaky, waxy, dandruffy looking. It's associated, this is more like test question-y, but associated with Malassezia furfur, which is a type of fungal infection. And the treatment is 2% ketoconazole shampoo or cream or a low potency topical steroid. This can be seen on the scalp in infants, and it's called cradle cap, but it's the same type of dermatitis. And for that, it's just emollients and gentle shampooing, really reassurance. So you might see this, like we see sometimes something like this at the Allen. Someone brings in their newborn, their 3-week-old who has this, and it's really reassurance. This is gonna go away, but some shampoos might help. Really, it's just time. Other dermatitis, exfoliative dermatitis. This is a generalized term, actually. It's more of a, like, not a specific disease, but more a description of a skin issue you could have with various conditions. It can be something very serious when you have a lot of exfoliative skin, which we'll talk about later. But generally, there's erythema, there's scaling, and then there's sloughing. And it's seen mostly in males over 40. As often an underlying disease. And it can be treated like a burn if it's diffuse. So just keep that in mind for some other skin conditions we're going to talk about. Psoriasis, this is very common. It's not something we deal with in the ED too much, but it's a chronic papulosquamous lesion. You form plaques with silver scaling. That's usually the buzzword for psoriasis. It's often on extensor surface as opposed to the flexural surfaces of eczema. It can be associated with nail pitting. It's often inherited. 30% of people with psoriasis also have psoriatic arthritis. There are these treatments like methotrexate and topical steroids. I don't think anyone's doing that anymore because if you have ever watched television, you would know that there are like 1,000 biologic agents now for psoriatic arthritis. So I do not list all these because I don't know them well enough to like go into them, but it's changed quite a bit how that's treated. All right, into some maybe slightly more interesting things. Pityriasis rosea, or things I like better. It's actually unclear what causes this, but it's probably a virus. It affects older kids and young adults in the spring and fall. I haven't seen this since I've been in New York. I haven't seen it since residency. It is not contagious. It is self-limited, but it lasts a long time. Like this can go on for over 2 months. So if you do see it, it's important to keep that, tell a patient that. So the like test question stuff is that you might start with a Herald patch, which is a single lesion, usually on the back, somewhere on the trunk, that's sort of in that Christmas tree configuration. So it follows the lines of the Christmas tree, but they'll just be one. And then a couple weeks later, you'll have this big eruption of these patches in a Christmas tree configuration, which is this pityriasis rosea, but have to consider also that there could be a drug reaction or it could be syphilis. It's really just conservative treatment. It should resolve on its own. Erythema nodosum is also another skin condition that in itself is not its own disease. It's just signifying other diseases. But it's important to recognize in the ED. So it's very distinct red-purple nodules that are tender, and they can be up to 5 centimeters wide, which is pretty big. Usually seen most commonly on the shins or other extensor surface. When you see it, think of, and also on an exam, think of sarcoidosis. It can be a marker for that. And if you see a triad of this erythema nodosum with bilateral hilar adenopathy on X-ray and arthralgias, you think of Lofgren syndrome, which is a type of sarcoid that has a good prognosis, but that's very much a test question. We also see erythema nodosum in coccidiomycosis. inflammatory bowel diseases, leukemias, lymphomas, TB, and some drug reactions. So it's kind of a not super specific, but definitely keep the sarcoid in your mind. And the treatment is whatever the underlying disease is that's causing it. Another one that has a rash, it's distinctive, is Kawasaki disease. I think it's more commonly known as mucocutaneous lymph node syndrome. This is a vasculitis of unclear etiology, and it's usually children under 5. So probably most of you guys have seen this more recently than I have. To diagnose it, you need fever for 5 days plus 4 of the following, which is this rash, which is scarlatiniform, morbilliform, bilateral conjunctivitis, lymphadenopathy, oral mucosal changes, which is the catchphrase there is strawberry tongue, which this is a picture of, or edema or desquamation of the extremity. So 4 to 5 of those for the diagnosis. The treatment is aspirin and IVIG. Steroids can be effective in groups, for example, apparently Japanese groups who have a high resistance to IVIG. And the dreaded complication is a coronary artery aneurysm, which can cause cardiac death. So that's why this must be treated. More pediatric stuff. Impetigo, this is fairly common, caused by staph or strep, but more staph. Very contagious, common in children. I guess adults get this too, but I've never seen adults with it. Often on the face in a picture just like this one. And the evolution of this rash is you have some red macules or papules that become vesicles, sort of rupture, and they get this honey-colored crust, which is like pathognomonic for impetigo. This soaks and washes and things that maybe some of our patients might be tempted to do to resolve this could spread it, basically cause satellite lesions. The treatment is topical antibiotics like mupirocin for disease that looks like this, but if it's more widespread, has like extensive lesions or ecthyma, which is like ulcerations associated with impetigo, dicloxacillin or cephalosporin, or Clinda if there's a MRSA concern. So that's impetigo. Another thing I don't see very often is erysipelas, but it's definitely something you might need to know on a test or may see. This is a superficial cellulitis. That's a burning, bright red, shiny plaque. It's a very well demarcated, and there's what they call an elevated advancing margin. So the part that looks like it's spreading is a little bit raised. This is usually due to group A strep. This is seen in extremes of age, usually on the legs, sometimes of the face. And you can have fevers, chills, some systemic symptoms that go along with it. And the treatment, antibiotics can be dicloxacillin, cephalosporins, Clinda, doxy, whether or not you want MRSA coverage. More xanthums, another thing. This is a thing I have never seen, scarlet fever. Maybe you've seen it, Oz. This is caused by group A beta hemolytic strep. It's also called scarlatina. This is another rash with a very specific evolution of how it shows up. So this rash starts in the flexural creases, and it'll be red and punctate and blanches and is rough like sandpaper is a common term for scarlet fever, the rash for scarlet fever. And then there's some desquamation with healing, and that's like how the rash evolves. This is associated with pharyngitis, fever, circumoral pallor, and another strawberry tongue. And this is treated with penicillin or cephalosporins and macrolides if there's an allergy. More pediatric exanthems, hand, foot, and mouth disease. This is something that's is around a lot. So I'm sure you're seeing it a lot at CHONI, more in like the spring, the late winter, early spring. It's a Coxsackie virus. I'm sorry, I was wrong. I'm confusing this with something else. This is the hand, foot, and mouth disease is more summer, early fall. So ignore what I said. It's usually in children under 7, but it can affect adults. So it's a Coxsackie virus. You can have anorexia, malaise. The mouth can feel sore. There can be anterior oral vesicles on a red base that are painful. can ulcerate. And then there are skin lesions that are not painful, but you could see them anywhere, including the hands, the palms, the soles, the buttocks. The treatment is just symptomatic. So pain control for the mouth. And the major complication of this disease is having kids not take PO because their mouth hurts and they get dehydrated. So hydration and pain control is the main thing. More pediatric exanthems, erythema infectiosum, or Fifth disease. This is caused by parvovirus 19. This is also called slap cheek disease because it has this very pathognomonic red cheek look. It's an abrupt onset red rash on the cheeks that's a few days. Then you get a lacy or reticular sort of rash on the trunk that comes a couple days after the face and lasts a week. There's no specific treatment for this, but important test things to know about are in sickle cell disease, this can lead to aplastic anemia, and that it's also teratogenic and can cause hydrops fatalis. So, and those are like test question things to know about Fifth disease. Sixth disease, or roseola infantum. This is mostly caused by human herpes virus 6. This is mostly occurs in children 6 months to 3 years, so pretty young. This is another one with a pretty specific evolution, how the rash appears. So, or how all the symptoms appear. So there's a sudden onset of very high fever for a few days, plus or minus runny nose, cough, anorexia, and you might see febrile seizures here. It sort of tends to be there's an association. So the defervescence happens and then the rash comes. So that's pretty specific. High fever, maybe some other stuff. Fever goes away, rash appears. Pink blanching maculopapular discrete lesions on the trunk, and then it spreads to the face and the proximal extremity. So that's pretty specific for Sixth disease. More exanthems. There's so many pediatric exanthems. I have a chat. Okay. Sorry. Measles are also known as rubeola. This is a myxovirus and it occurs in the winter or the spring. There's a 10-day incubation period and then a few days of prodrome with fever, malaise. There's this whole triple C cough, coryza, and conjunctivitis, which you may have, and then Koplik spots, which I don't know how easy it is to see these Koplik spots. I've mostly just seen them in pictures in books, but they're red, they're blanching. The rash is red and blanching. The Koplik spots are back next to the molars. So it's supposed to be, this is, I'd say, more of a test question, but if you see it in real life, congratulations. But the rash progresses from head to feet. So it's like pouring a can of paint over you. So that's a good one to remember as well. The treatment is supportive, but the complications are horrible, which is why we care so much about people getting treated for measles. You can get acute disseminating encephalomyelitis, which is demyelinating disease that happens during recovery, or you can get SSPE, which is subacute sclerosing panencephalitis, which is progressive and degenerative disease of the CNS that happens years later. So measles has pretty devastating consequences. Rubella, which is German measles, is very uncommon. I've definitely never seen it. The incubation is long, like 2 weeks to 3 weeks. The prodrome is pretty nonspecific. The rash, again, is very fine, irregular, maculopapular, goes from the face to the neck to the trunk, the arms, and the legs. So that's kind of similar to how measles appeared, but then it clears in the order it appeared, which is pretty cool and sort of pathognomonic. And then the other thing that was sort of seemed like a specific thing to rubella is posterior occipital lymphadenopathy. Treatment again is supportive. And this is a picture of a baby with all these blue spots who got it in utero. And it's definitely teratogenic. And they called, I don't know, when I was training, they called this like a blueberry muffin baby or something. That's probably like a bad thing to say now. But I always remembered it. More, this could be anyone, but often pediatric. Exanthems, chickenpox, which comes from VZV, which is a herpes virus, often children less than 10, late winter, early spring, this one. Very contagious, starting with the prodrome all the way until all the lesions are crusted over. You have some vague viral symptoms to start out, and the lesions start on the scalp and the trunk. And then they become vesicles with a red base, which has this other silly pathognomonic dewdrop on a rose petal description, and then they dry and crust over. The palms and soles are spared, and the lesions, this is another chickenpox thing, are in various stages of development. So some will be vesicles, some will be crusted over. They all look different from each other. Important thing, but not so relevant because we don't give aspirin to kids very often, but no, don't give aspirin to kids with chickenpox, because you can get Ray syndrome, which is a rapidly progressive encephalopathy with hepatic dysfunction, which you can get. It was much more common like 40 years ago, but it was associated with aspirin use in varicella or influenza. And now it's like 1 in a million, because no one does it anymore, but it's a test question. Adults could get pneumonia or encephalitis from this. If immune compromised or pregnant, you will be given immune globulin. And people are now vaccinated, so this is becoming pretty uncommon to see chickenpox. What we do still see is herpes zoster infection, which is shingles caused by VZV, and this is just a reactivation of latent chickenpox, generally. This starts with pain that precedes a rash by 3 to 5 days. So we do see this a lot, and keep it in mind when you're seeing someone with severe, very focal pain, frequently somewhere on the trunk, but it also can be like, V1 of the trigeminal nerve. If they don't have a rash yet, still try to remember to consider it and mention it to the patient. That, be on the lookout for a rash if it really seems like a severe like nerve pain in a patch like this. So then the rash can occur in any single dermatome, often on the trunk, starts with erythematous papules, and then there becomes clusters of vesicles within erythematous base. This rash is always all at the same stage. The whole rash changes at the same time. So it's in contrast to the chickenpox rash where everything can be at different phases. So you can have cranial nerve 5 involvement. So you can have the ophthalmic division, which can give you herpes zoster ophthalmicus. That might show a Hutchinson. I'm going to show you pictures of this, but that might be tipped off by a Hutchinson sign with a lesion on the tip of the nose. And if there's concern for ophthalmic involvement, then you could have a dendriform corneal ulcer, which is a complication that we care about and needs treatment. So another type of involvement is cranial nerve 7 or 8. You can have Ramsay-Hunt syndrome involving a facial nerve palsy, involving the ear, and treatment is generally an antiviral. And for postherpetic neuralgia, which is pretty severe, gabapentin and carbamazepine are the most commonly prescribed, not necessarily in the ED, but are the best for that pain. Also, this has a vaccine, so hopefully we will start to see less of this too. So this is shingles, all in its distribution in the patch of one dermatome. Here's a facial nerve, Ramsay-Hunt syndrome with lesions around the ear. Here's a Hutchinson sign and shingles around the V1 or trigeminal first branch division, and then the lesions in the eye on eye exam. So those people who have the eye involvement need to see opto and have a full exam. Okay, more fun things. We have herpes simplex. HSV1 is pretty common, is really common, transmitted by contact of infected secretions, saliva or genital, with mucous membranes or open skin. HSV1 is generally thought of as the oral lesions, but it can cause genital lesions. There's vesicles on a red base, lasts a couple weeks, pretty painful. This can be recurrent, but it can be, the recurrence are often triggered by stress or trauma or sunburn. And then HSV2, more often genital, but as we said, either one can go on either side, either place. This is very painful. You'll have pustules and vesicles on a red base. The outbreak will happen a week or a little more after an exposure. There can be ulceration, which is really painful, and then the ulcers can kind of coalesce into bigger ulcers. There's often tender inguinal lymphadenopathy. Often you have a systemic, especially with the first exposure, systemic feelings like malaise. And treatment is acyclovir and valcyclovir for both herpes 1 and 2. All right, this slides us into some more STDs, because those often come with fun rashes. So gonococcemia is when Neisseria gonorrhea becomes systemic. In less than 3% of untreated patients of gonorrhea get disseminated infection. That still seems like probably a lot, but I've never seen this. I don't think I've ever seen it. So the initial stage includes possibilities of myalgias, these skin lesions, which are these like necrotic tender pustules with a red base, like that you see in the picture, can be on the palms or soles, but is definitely tender. You can have tenosynovitis. Now, this can be followed with mono or oligoarticular arthritis with purulent synovial fluid. So it's important to think of this potentially when you have someone with what you're concerned for is a septic joint, and try to remember to ask history questions that would lead you to this as well, to consider that this could be the cause of a septic joint. The treatment is ceftriaxone IV daily for 7 to 10 days. So someone with this needs IV drugs. So IV antibiotics, they would need to be admitted. More STDs with more rashes, these are diseases that have like a ton of things to say about them. And we obviously can't cover all of the details of them, but important again to think of these when you see rashes in real life on an exam. Syphilis is caused by a spirochete, Treponema pallidum. There's a 3-week incubation, which is a pretty long incubation. First, there's the chancre, which is a skin lesion that's painless on the vulva or penis. It disappears in 3 to 6 weeks. It's around for a while, so there is a good opportunity to get treated early on if someone pays attention, but it is a painless lesion, and there should just be one. So if someone has a lot of genital lesions, it's probably not this. Don't think of this. The secondary phase, which is several weeks later, is very contagious. There's lymphadenopathy, and then there's this rash that starts on the trunk, again, a specific evolution of rash, and spreads out, can be on the palms and soles, as you see, is red and dull, is not pruritic. And then there could be mucosal lesions associated with this as well. And another part of another skin manifestation of secondary syphilis can be condyloma lata. So sort of like warty, flat, white lesions on the perineum. And this is all highly contagious. Tertiary syphilis is, I'm not going to go into it specifically, but neuro and cardiovascular involvement. And the treatment is penicillin or doxy if you're allergic. But just important to remember the rash of secondary syphilis is very contagious and can be missed. Okay, another very complicated disease that has a rash is Lyme's disease. This is caused by the spirochete Borrelia burgdorferi from a tick bite. The classic lesion you see here is the erythema migrans, which is like the bullseye, the erythematous patch with a central clearing. This is pathognomonic, but there are 20% or more of cases that don't get this rash at all. And it can happen a couple days or 3 weeks almost after a bite. So you have to keep it in mind and try to ask associated questions about whether or not someone has been exposed to deer ticks. This can come with some B symptoms like fever, myalgias, arthralgias. The complication of Lyme disease can be terrible. A chronic polyarthritis can be pretty severe. AV blocks are your cardiac and myocarditis or cardiac complication, Bell's palsy. And treatment is doxycycline. If there's a tick bite, if there's a possible tick exposure, you can give a prophylactic treatment. We don't do this much in the city, but prophylactic treatment of 200 milligrams, like a single dose, if someone comes in and thinks they've had a tick bite. If they already have this rash and we know they have Lyme, that means they've been bitten and it's being transmitted, then you do the whole course. The prophylactic dose is just for someone who's like, I think I was bitten by a tick and I don't have any symptoms. That's to stave off the infection. Rocky Mountain spotted fever. This does not actually occur in the Rocky Mountains. It occurs in southeastern US. How do you like that? But it's caused by Rickettsia rickettsii, and is another tick-borne infection in the spring or the summer. You'll have small pink macules that start on the extremities, including the palms and soles, which is an important piece of history. And then it extends from there inward, which is, again, a specific evolution that spares the face. And that's 80% of people have that exact type of progression. Blood work will be notable for low platelets and low sodium. So important to keep this in mind when you see this rash and check those things. And then some of the complications can be pretty severe, including DIC and requiring amputation and circulatory issues. So definitely want to check these things and keep it in mind. And the treatment is doxycycline. More rash diseases, ehrlichiosis. This is similar to Rocky Mountain spotted fever, but the spots are more like generalized and I guess harder to see. Also a tick bite, also associated with some beta symptoms, some B symptoms like fever, myalgias. The lab abnormalities there are a few more of them. So you still have low sodium, low platelets, but you can also have leukopenia, which seems like sort of the buzzword or the pathognomonic lab abnormality for ehrlichiosis. And you just check this if you suspect it. If you think someone has this weird rash, they might have had a tick bite, you're going to be checking their CBC, their elites, their LFTs. And the treatment is luckily also doxy. So that covers a lot of these infections. And again, a complication is DIC. So important to keep this in mind. All right, moving in a little bit of a different direction, we have cellulitis, which we're very familiar with. We see this a lot. This is local soft tissue inflammatory reaction from a bacterial invasion of the skin, more common in elderly people, immunocompromised people, and people with peripheral vascular disease. And you know how this looks: pain, induration, warmth, erythema, most commonly staph and strep. And our antibiotics treat staph and strep, and you have to consider MRSA. Remember to consider DVT if you see this leg too. Other soft tissue infections that have rash are necrotizing soft tissue infections like neck fash are one of our scarier rashes. This is usually polymicrobial. It can be group A strep, it can be Clostridia, but usually it's multiple organisms. Some of the pathognomonic things here are pain out of proportion to exam. You start with erythema and some edema, and that turns into discolorations with vesicles and bullae, and then crepitus is kind of a late finding. So once you find crepitus, you're in pretty big trouble. It's pretty hard to find, to figure this out early then. Increased risk with IV drug abuse, with diabetes and other immune suppressing conditions. If this infection comes from a traumatic wound or a post-surgical wound, Clostridium is often the cause. Consider Fournier's gangrene. And then treatment is very broad: antibiotics with IV fluids, blood products if needed, and is considered a surgical emergency. Here's some terrible bullae and erythema that's maybe going up and becoming a Fournier's. And here's an x-ray with some gas, sub-Q gas, which is also a pretty bad sign. Okay, how are we doing? 10:09. Oh gosh, there's so many rashes. I'll try to go faster. Purpura. So purpura is, again, the non-blanching rash that's extravasated blood. classically Hennig-Schonlein purpura, which I think no one calls it that anymore, probably. I think it's called immune globulin A vasculitis. This is a syndrome associated with vasculitis associated with nephritis, GI bleeding, abdominal pain, hematuria, some joint inflammation, and this is often after an infection, and the age range is between 3 and 15. And one thing to know is that a lesion in the intestine can serve as a lead point for intussusception. But this is a characteristic, like lower extremity palpable purpura on the buttocks, the backs of the legs. And this is self-limited. This can resolve spontaneously, but if admission is warranted because of abnormal kidney function or GI bleeding or severe pain, then some people, kids can be admitted for hydration and pain control, steroids if really severe. This is the most common vasculitis of childhood. Another place you might see purpura, hopefully not, but very important to notice this other disease with purpura on the legs, which would be meningococcemia, which is Neisseria that has become widespread, disseminated. This is spread by aerosolized droplets from carriers. Apparently a lot of the population is a carrier, or from an infected patient. And this is in closed confined populations in young people. So this is like dorms and prisons, have a high suspicion for dorms and prisons. Acute illness can include pharyngitis, which is important to remember because I always think if they have pharyngitis, I'm like not having to worry about meningitis, but you still have to worry. Meningitis, bacteremia, and the rash has these petechial or purpural lesions, often on the lower extremities, that can become hemorrhagic and have vesicles and bullae. Prophylaxis from exposure is Cipro or rifampin, and treatment is ceftriaxone and vancomycin. Often we'll be treating more broadly than that and treating for like listeria. Mortality is 13%. It's pretty high. Okay. Toxic infectious erythemas. One is toxic shock syndrome. If we were talking, I would want to know if people had seen this, but I don't think it's seen that often anymore. But it's multisystem illness with fever, shock, and erythroderma that leads to desquamation, which, as I said, can be very, very serious. And this is one of those cases where it's serious. This is caused by staph. 4 major criteria is a fever over 102, the skin finding of erythroderma that becomes desquamation, mucous membrane involvement, and low blood pressure. And then also 3 system involvement you need for the diagnosis as well. There's also strep toxic shock, which is basically the same as staph toxic shock, except there's often a cellulitis associated with it, and there's a worse mortality. The treatment is just treating shock, so surgical debridement if needed. If there's terrible desquamation, they might need to be treated like a burn. Antibiotics that treat staph and strep, broad, but those indeed. Staph scalded skin syndrome, which is another thing I have not seen personally. Usually occurs in children under 2. This is a staph infection that secretes an exotoxin which detaches the epidermis, which is horrifying. There are 3 phases. Again, there's erythroderma, then there's an exfoliative phase and a desquamation with recovery. There's fever, there's another scarlatiniform rash, which is again that rough sandpaper rash. You can have bullae and vesicles that appear in rupture. This one has a Nikolsky sign, which is when you sort of rub the skin along the plane of the skin, some of it sloughs off. That's like another sort of test question that people love to ask. So definitely worthwhile remembering the Nikolsky sign diseases. And treatment is antibiotics for staph, IV fluid, electrolyte management. Okay, bullous diseases. There are a couple of bullous diseases that you have to be familiar with. One is pemphigus vulgaris. I always found it hard to remember the difference between pemphigus vulgaris and bullous pemphigoid. And eventually I remembered that I thought vulgaris sounded worse because it's vulgar. So this is the worst one. This is a mucocutaneous autoimmune blistering eruption, happens between ages 40 to 60. Lesions are vesicles and bullae, so that's just blisters of varying size, right? Start on the head and the trunk. They're clear, tense blisters, and they can often be bullae, big. After a few days, the lesions become turbid, so the liquid is less clear, and they become flaccid, and then they rupture, and that's when pain comes. And now you're susceptible to secondary infection, which would be the reason maybe you have to admit these people for sure. And another reason is that most of them have mucous membrane involvement, which can cause dehydration. This is another disease with Nikolsky sign. So remember this one too. Treatment is to hospitalize, get derm involved, give IV, high dose IV steroids, and treat these lesions as burns. The other bullous disease you should know is bullous pemphigoid, which is a benign disease. This is a chronic mucocutaneous blistering. It's usually elderly people. It's more female than male. There are big, tense blisters, or bullae, as we should say, not blisters, often in flexural areas. And there can be some mucous membrane involvement. This one has a negative Nikolsky, so it's another way to distinguish. But pemphigus vulgaris is high-dose steroids treatment, and this is steroid treatment, but you don't necessarily need hospital admission unless these wounds are like, there's a lot of open skin and you're really concerned about bacterial superinfection. Okay, erythema multiforme. This is a skin finding associated with disease and not quite its own disease again. This is another type 4 hypersensitivity reaction that can be associated with infections, mycoplasma, herpes. It can be associated with a drug reaction. Sulfa is a hot one, or some oral hypoglycemics, some anti-epileptics. The lesions are red erythematous papules that become maculopapules and then target lesions. And then they can also then vesiculate or become bullae. EM minor is mostly just the skin, mostly self-limited. Topical steroids can be enough for it. EM major is when you get to a severe disease like Stevens-Johnson syndrome. This is just a picture of what these lesions can look like. So on to Stevens-Johnson. This is EM major. This is a severe form that has bullae involvement and can cover up to almost a third of the body surface area. It has mucosal involvement. There's a big risk for electrolyte abnormalities, secondary infections from exposed dermis, dehydration, associated with conjunctivitis, mucositis, stomatitis. This requires ICU admission and derm consultation and can be fatal. Another bad one that's in the same family as Stevens-Johnson's is toxic epidermal necrolysis, or TEN. That's just covering more surface area than Stevens-Johnson. It's explosive inflammatory skin disease, usually drug exposure. Again, think about sulfa, also barbiturates, anti-epileptics. This one has a Nikolsky's again, so this is the third one we're seeing with Nikolsky's. So remember that. Death can be from hypovolemia, electrolyte abnormalities, or infections, like a bacterial infection. And this is a 30% mortality. Pretty severe. Treatment's the same: fluids, electrolyte repletion, treat skin lesions as burns, ICU admission. And look how scary that is. So that's what TEN can look like. Then we have some sort of like, oh, we're almost done, you guys. We have some more benign lesions to finish out. So we have tinea. Now there are several types of tinea, and they're each like named for the body part they affect, but this is infection of keratinized tissue. This can be seen on a potassium hydroxide prep if we did those. We did them in my residency ED, but I don't think we don't do them here. If it's affecting the scalp, it's called tinea capitis. If it affects the beard, it's called tinea barb. And when it's in a place with hair, like these places, You can get a scaly patch that's sort of thick and raised, and that's called a carrion nodule. Tinea can affect, if you just have it on your body, it's called tinea corporis, which is also called ringworm. And that's an annular lesion with a clear central part. Tinea pedis is commonly known as athlete's foot. Tinea cruris is jock itch, which is in the groin but not on the scrotum. And the treatment is antifungals. Often people start with topical and then it doesn't work and then they move to oral. Here's a picture of the carrion. And this is a picture of tinea corporis or ringworm. Then there's lice, which somehow falls into derm, although it's not exactly derm, but head lice, nits or eggs attached to the hair shaft that are usually found on the scalp and the neck where there's hair on the neck. Body lice, you'll see linear excoriations, which expares the hands and feet, which is good to keep in mind. And they live on the clothing and travel on the skin to get blood and then hide in the clothing again. So this is like something we might see in our undomiciled or shelter patients, just because it's very hard to clean your things in that social situation and very easy to spread. Pubic lice is considered a sexually transmitted disease. It's very pruritic. You're only going to see this on exam. So this is someone who's having like very severe groin itching and it needs to be looked at. And there can be some urticaria on the thighs or the lower abdomen. The treatment for all these types of lice is permethrin, 1% rinse. And like really the big problem is cleaning all the clothes, the bedding, things like that, especially in the shelter population. Scabies is a skin infestation by Scarcoptes scabii or skin mite. It burrows between skin layers. It causes very severe itching, usually in the thin skin. Like the head and the face are not affected. It's usually thin skin, like maybe on the hands, like you see in this picture. The treatment for this is 5% permethrin cream or lindane lotion, only if you're over 2. Topical steroids can help. Oral antihistamines can help as needed for symptomatic relief. We're going to make it. Some pearls. Always think of STDs when you see rashes in real life and on exams. Pay attention to the age and especially on a test question, like if this person hiked somewhere, went to, the Southwest or the Southeast. Definitely notice the locations and evolution of the rash. Where did the rash start? How has it spread? Always ask patients about new medications in the last couple of months, or at least the last month, and any changes in their medicines, and learn the Nikolsky sign and like which diseases have that. There are a couple of questions, but I'm not gonna go do them since no one's here. So good luck. Sorry it's so boring and dry. And that's it.
I think you're right. It is important to kind of learn the descriptive terms that are used, especially if you don't want to sound like an idiot when you're calling the dermatologist. I think they appreciate it a lot when you can describe what you see. I have to say though that the fact that we can take photos now and put them in charts, pictures are worth 1,000 words, and so maybe it won't be as important in the long run.
Oh, right.
But the dermatologists, I think, have a lot easier time of helping us, especially me being a nocturnist and calling them in the middle of the night when they don't want to get up and come in.
You're so right. It actually really does not matter as much anymore. That's just like an old school, like
although it does make you feel smarter when you can actually use the correct terms.
Totally.
But that was a great review, and every time I see it, I retain a little bit more each time.
Really?
Oh yeah, sure. Yeah.
Oh,
Well, I'm telling you, if you work in fast track, it's not an uncommon complaint to have in fast track. It may not be as important in the main ED, although recognizing neck fash is is huge for the patient. So,
I mean, it really is involved in, so there are rashes in so many like important diseases, that it's pretty worth like remembering to consider, like I said, the STDs and stuff.
and it's, you know, it's very disturbing to patients, right? I mean,
Right.
it bothers, you know, it can be very symptomatic, very itchy.
Yeah.
It can be, you know, uncomfortable. It can also worry them that they have something contagious, right? That they could spread it to other people. So,
Totally.
and like you said, our homeless population, it's just so difficult, if they develop rashes to properly treat them. So you want to make sure that if it really is something that the effort of getting them to get rid of all their clothes, and I mean, I don't know about washing clothes. I think in the case of the homeless, most of the time you're providing them with new clothes, but they have to bathe and get it off their skin. And
Yeah.
um,
Very
but thank you so much. It's definitely one of the areas I think that EM docs, you're either really good at it or you suck at it.
I
And
think most of us are not confident about rashes. Like I feel
yeah,
like I overhear our colleagues consulting each other over rashes more than many other things. Like, will you come just look at this rash?
I mean, you know, in the end, it's really like anything else. We want to make sure that we will rule out the killer stuff, and that we, you know, the stuff that's, if it's not TN, then, you know, they can go to clinic in the morning if you get
Right. Well,
arranged
that's
for
the
it.
thing. And that's actually usually how I practice, because we don't always know what a rash is. It's often isolated and it's not like fitting any of these categories. And I'm like, if this is not a sick person, they don't have this, or this, like they're going to follow up. But
Yeah.
since,
I mean, you know,
this
how many
board
times does
review,
dermatology need a biopsy to figure it out? I mean, we're not gonna,
right.
so it's not surprising that we're not always as completely comfortable, but I like, you know, it's wonderful when they actually come and they impart their knowledge, although most of the time they're then giving you a laundry list of labs to send
Right.
to rule out all the enodosum possible causes and all that other stuff. But you know, I think that for residents, it's important when you call a consult, um, you know, any consult, but you know, now we're talking about derm, you know, pick their brains for how they're going through it and how they're figuring it out. I think to lose the opportunity to learn from them is just a lost opportunity for making yourself a better provider. You don't always have dermatologists available to you. So
Absolutely.
anyway, thank you so much, Raleigh, for your time.
Thank you, Oz. Have a great
And
night. Get some
yep,
rest.
will do. Well, I'm off tonight, so I'm so happy.
I would hope so. Oh my God.
Now, sometimes I go to work right now, but
Oh my
all
God.
right.
All
Good
right.
night, everybody.
Later. Bye-bye.
Thank you.
Bye, Gail.